Good morning all, and welcome to our breakfast series. Sorry about the slight delay. We had a few technical issues, but which hopefully are solved. We're just going to wait a few more minutes for a few more attendees to arrive. So grab yourself a coffee, something to eat, etc., and make yourself comfortable because we've got a great morning ahead. And yeah, we should get cracking soon. Okay. Okay. For those who are just arriving, good morning. Welcome to our breakfast series. We're just waiting a few more minutes for a few more attendees to arrive, and then we will start. Good morning all. Okay, I think it's 7 minutes past 10 and we will start with our webinar breakfast series. So welcome all, I'm Jar and I'm joined by Sam. We're both part of the TRIPOM education team and trainees in anaesthesia based in the UK. So a warm welcome to all of you in joining our third and last of the breakfast series on the perioperative care update, challenges and solutions in the COVID-19 era. These webinars are brought to you by TRIPOM and the generous sponsorship by Edward Life Sciences. During the past 2 weeks, we've had immensely interesting talks ranging from preparations for surgery to intraoperative management for patients in a COVID setting, delivered by our international panel of experts and joined by attendees from parts of UK and around the world. These sessions are recorded, so if you missed out previously, we will be posting them on our TRIPOM website. This morning, we've got 2 great talks lined up, and to highlight that this is an interactive session, so if you have any questions for our speakers, please use the questions tab on the GoToWebinar console, and my co-organizer Sam will present the top 3 to our panelists. So without any further delay, it gives me great pleasure to introduce our first speaker, Dr. Jim Buckley. He's a consultant in intensive care and infectious diseases at the Royal Free Hospital in London, which is a high consequence infectious disease centre, facilitating high-level isolation for infected patients. He has a wealth of knowledge in treating patients with Ebola, Lassa fever and MERS, and of course he has gathered a plethora of experience during the first wave of the COVID pandemic, which I'm sure he will share with us. He's got a great talk lined up this morning, so I'm just going to hand over to you, Jim. Okay.
Thanks, Shai. Morning, everyone. So, hopefully you can see my slides. I've put up my Twitter handle and feel free to follow me on Twitter as well. I usually just tweet some educational info, and certainly during the COVID pandemic, that's been the majority of what we've shared. So I'm going to just give you an overview at the beginning. I'm going to go through some of the virology. I'm going to talk through some of the epidemiology of the first wave, and certainly that on ICU. And then we will talk through the clinical presentation and management on ICU as well as the treatment. And I will just give an overview of this. I'm going to make an assumption that most of you have been involved in managing and treating the patients on the ITU, and really I'm trying to give a slightly different perspective to allow you to put the perioperative management in context so we can view this in the bigger picture. We'll talk about the current epidemiology and also some of the ongoing trials. So really, at the end of December in sort of 2019, WHO China really started to report this novel pneumonia. And really, they were baffled by the etiology, and it was centered in Wuhan, which has an expert category 4 virology center and research unit of world renown. By the 7th of January, however, the novel coronavirus had been identified in China, and then it was on the 9th of January that the WHO announced that the novel coronavirus was responsible for the pneumonia of unknown etiology. Now, all of this already feels like a lifetime ago, but really it is absolutely remarkable what we've all been through, what we've dealt with, and what we've learned about this virus so far. The first exported case was reported in Thailand then on the 13th of January. And at that stage, it really was defined as a high consequence infectious disease, which was useful because it put us all on alert at a global level to be on our guard and that take this seriously. So therefore, looking at the definition of a high consequence infectious disease, it has to be an acute infectious disease, typically has a high case fatality rate, may not actually have effective prophylaxis or treatment, is often difficult to recognize and detect rapidly, has the ability to spread in the community and within healthcare settings, and requires a specialist response. Now, for those of you in the know, you'll realize that very rapidly, COVID-19 was downgraded in the UK from being a high consequence infectious disease. And one could argue that currently the disease still fulfills many of these characteristics. So it is still an acute infectious disease. One can argue that the case fatality rate isn't that high. So it will vary. So if we take an approximation currently at 1%, that's the least disputed number that we can argue in terms of the overall case fatality rate. That doesn't seem very high. But if you're ill enough to end up on intensive care, then in the United Kingdom, that can be as high as 34, 35%. And considering that Ebola in the first world center on intensive care has a mortality of 40%, that's still a pretty frightening illness. We are now starting to see effective treatment and maybe even prophylaxis, and I'll talk through some of this. It is easier to recognize, and we are better at detecting it rapidly. So one could argue these are acceptable reasons to downgrade it from an HCID. But it certainly still has the ability to spread in the community and within the healthcare settings. And for those of you who keep an eye on the stats and the statistics, and I'm sure we've all sort of been watching news, it's thought that up to 12% of all infections in the first wave actually happened in the hospital environment, and that's quite scary. Now, if we look at coronaviruses, so SARS-CoV-2 is a member of the beta-2b coronavirus subset, and therefore it is very closely related to SARS-CoV-1, which caused the SARS outbreak. And they both share the fact that they bind to the ACE2 receptor. MERS-CoV, which caused Middle Eastern coronavirus disease, is a member of the beta-2c subtype. But already we're starting to see data from the genetics of this that allowed us to have a very early warning this was going to cause a problem. SARS, the disease from 2002, had a 10% case fatality rate, and MERS-CoV has a 35% case fatality rate. And indeed, one of the reasons that the Royal Free had been prepared as a sort of a high consequence infectious diseases unit was really for a MERS-CoV outbreak. So the fact that this wasn't MERS-CoV, but a similarly sort of transmitted virus and equally worrying, meant that we were one step ahead of the virus, or so we thought. And really, within 48 hours to 72 hours of dealing with this disease, we really realized that we were not ahead of this virus or this disease at all. Now, novel coronaviruses emerge because they infect many other mammalian species. And bats are absolutely fascinating because there are up to 1,400 species of bat, and there are up to 300 different types of coronavirus in each bat. And the bat immune system is phenomenal. So human beings fight viruses through our sort of interferon system, and the bat immune system has an immune system whereby the interferon pathway is always on. And this is phenomenal. So human beings will only switch on their interferon pathway when we are fighting an infection. But bats, it is always on. So this is great for the bat. But the trouble is, this leads to the rapid evolution and development of many other novel species of viruses in bats. Now, the fruit bat that is thought to be the original host of SARS-CoV-2 virus actually exists in the wild 1,000 miles south of Wuhan. And so this is where all of the conspiracy theories come in about how it got to Wuhan and how it sort of was released from Wuhan and how it started to infect people in Wuhan. But it's certainly possible that it was transmitted to human beings via pangolins as an intermediate host. And this is not impossible. And we know that the civet cat was responsible, played a role in SARS, and camels play a role in MERS-CoV. And if we look at the biology, it's actually twice the size. SARS-CoV-2 is twice the size of many other coronaviruses, but down the electron microscope, you still see the typical corona with the spike proteins, as well as the envelope proteins and the nucleocapsid proteins. And indeed, the spike proteins and the envelope proteins are key both for our immune system recognizing them, also part of the pathogenicity, and also really important in the development of vaccines. And if we look at some data looking at the time frame and chronology of when we can detect this virus and when we can pick up antibodies, if we look at the blue line here, we can see that nasopharyngeal swabs are PCR positive probably 1 week before symptoms, up to 1 week before symptoms present, and can be present for some time afterwards. I've got a colleague that was positive for 40 days afterwards. This slide suggests that the PCR from the nasopharyngeal swab can be positive up to 6 weeks. And up until recently, we've truly believed that this is dead RNA. Now, certainly at the Royal Free, we've had 2 cases where we believe this RNA that we were picking up in the nasopharyngeal and airways was representative of live virus, because we were also able to pick it up in the blood PCR, and this also fitted with the chronology of the clinical symptoms of resurgence of pulmonary disease as well as hemophagocytosis. Now, it is theoretically possible that this dead RNA was just acting as an antigen, and this was all immune-mediated disease, and we're still waiting proof that we're able to culture the virus from these samples later on. We will start to produce IgM within 4 days and IgG within about the first 14 days of infection. And the real question is this a neutralizing virus antibody? Will it neutralize the virus? And how long will it be sustained? Now, there's reasonable evidence that these are neutralizing antibodies, and there's emerging data that actually after 3 months, the human IgG response specific to SARS-CoV may start to wane, and hence the whole concept that we may not have sustained immunity. However, we are hanging our hat on the concept of innate immunity and our T-cell responses really protecting us against this. Now, this is important and useful because there is reasonable evidence that whilst the IgG response will be specific to SARS-CoV-2, the T-cell response and the innate immunity responses to other coronaviruses do show an overlap. And so therefore, past colds due to coronavirus may well protect us against this. Now, I'm going to summarize our clinical presentation because I'm sure other speakers have gone through this. You've all dealt with it. But I do not mind confessing that we were all prepared for a severe flu-like illness. And this is a Russian doll, because every time we thought we understood this illness, another facet of the pathophysiology of this virus came to light. So we were pretty much prepared that there would be an inflammatory component. We had a heads up that we may have a pro-inflammatory cytokine response. And I know that Professor Pearse has interesting sort of opposite viewpoints on this as well, but we can discuss that later maybe. The surprising thing was the prothrombotic component. And because we ran these patients dry initially, we thought that it was an iatrogenic renal injury, but we now know that this virus will bind to ACE2 receptors in the kidney, and we know that there is a sort of a paracrine cytokine response within the kidney that is very pro-inflammatory as well. The cardiac consequences have been well documented. The neurological consequences are absolutely legion, going from the direct inflammatory to the post-inflammatory GBS type syndrome, as well as the media now sort of really presenting a lot on the long COVID type illness. And this is a real challenge. And that's without going into all of the psychological issues about relatively healthy people being ill for a prolonged period of time, irrespective of being on intensive care, And this is irrespective of all of the financial consequences of not being able to work and of the global economy absolutely being destroyed. If we now look at the UK ICNARC data and look at the breakdown of the incidence and prevalence of the disease across intensive care units in the United Kingdom, we can see that the south of London was hard hit with over 1,800 cases, followed by the east of England and then the north, central and northwest London. And it may well be that on this slide, which represents the first wave, it may well represent that the intensive care units with the lower incidence of prevalence are now being hit hard. And I'm aware from several sort of web calls yesterday that the northwest is really struggling and are now starting to see their intensive care units filling up and spilling over beyond their normal cohort. On this slide, I really want to pick out the two simple things. It's a male predominant disease and it has a significant predilection for non-white ethnicities. Now, this is highly likely to be due to socioeconomic factors, including occupation, the density of housing, and any elements of poverty, as well as the inability to shield or work from home. However, this week there's an interesting paper in Science that has picked up two mutations. There's a mutation in the interferon pathway in some human beings that are being affected really badly, and the team have also picked up autoantibodies against interferon that also have a higher incidence and prevalence in males who've been significantly crippled by this disease. And so therefore, like any infection, one needs to look at the triad of the pathogen, the host, and the environment. And so therefore we're learning more about the pathogen, we're learning more about the host, and I really do think it's the socioeconomic reasons and density of housing and density of population that then look at the environment and the ability to work from home. And I think as we go through, we will learn more about this. I find the density of the population in Sweden quite interesting, and of course in the cities they are dense areas, and so therefore the question is it a genetic issue and not just the host and not just their great epidemiology and public health in Sweden. Looking at the summary data of ICNARC, therefore, in our last few closing slides, over 10,600 patients were infected, with 38.7% dying on the intensive care and a further 4% dying once they left the ITU. So really we're looking at a 40 to 41% mortality overall. At the Royal Free, our mortality was down at about the 28 to 30% mark, but I'm sure that as we go forward throughout the UK, then we will have a lower mortality as we better learn how to treat and manage this disease. So going through the basics for you on the ground in the perioperative management, looking at the intensive care unit, get the patient into a side room, make sure you're wearing the appropriate PPE, be able to differentiate the higher risk scenarios of an aerosol generating procedure. At the Royal Free, we include a CTPA, D-dimer, ferritin and HIV test as our baseline bloods. We've taken deep pulmonary samples with an intratracheal aspirate for all of our cases, as well as a blood EPTA. And I would recommend a baseline beta-D-glucan and galactomannan because there is an increased association of aspergillus infection in COVID. We've routinely been doing thromboelastographs in our admissions, recognizing they're procoagulant and being able to utilize that to adjust our anticoagulation, especially if the patient has a negative CTPA. There is increasing debate about the need to have concomitant antibiotics to cover a bacterial superadded infection, and I would recommend if the patient is sick that we cover, take some deep samples and then have a rapid de-escalation so we're not driving antimicrobial resistance. I think a low threshold for therapeutic anticoagulation, early admission to intensive care, and a regular review of the ceilings of treatment. Here in the United Kingdom, we've had 16,000 people die in care homes in the first wave, and I'm not sure society will tolerate or accept that number of deaths in the care home environment in the second wave. And I think this will be a challenge for us clinically and also interesting on a population basis. NIV and Octaflow were initially suggested to increase mortality, and there's now clear emerging data that these really are effective treatments if used early with the awake proning technique as well. If the patient is strong enough and fit enough to prone themselves, they should be proned whilst awake, even pre-ICU. If they're not fit enough to prone themselves, I would recommend they probably should not be proned in the awake state. And even fluid balance, lung protective ventilation, early proning on the ventilator in general, and an early referral for ECMO, which has very low, very high survival rates and low mortality, although we can argue about the evidence base for ECMO in due course. So now on to the treatment. Early use of dexamethasone, 6 milligrams once a day for 10 days, as soon as the patient is in hospital and requiring oxygen. This can be IV or oral. Immediate loading with remdesivir once we've proven the infection with 200 milligrams stat, and then 100 milligrams once a day for 5 days or 10 days. Now, recent trials and studies coming out should suggest that 10 days offers no added benefit over 5 days, and in the context of a shortage of remdesivir globally because of the US being able to purchase the rest of the entire global stock of it, then shortening the duration to 5 days, if there is an evidence base for that, is worthwhile, and that's what we've been doing. The remdesivir data really is not as strong as the dexamethasone data, and it definitely decreases the duration of symptoms, but does not have a clear impact on mortality. And these are the graphs and survival data for dexamethasone decreasing mortality in the top right-hand corner. Globally, we are looking at a major problem, and this chart is from the WHO website, and it's already out of date. And the deep brown is 1,000 cases per million of population in the preceding 7 days, and we know that this has increased since then. Europe is a medium brown, and the British Isles are certainly a sort of darker orange colour and evolving. Last slide. Going through the global epidemiology, it is very interesting that the incidence is increasing globally, the mortality seems to settle, but if we go through each region, the mortality in Europe right now is very discordant with the incidence. One hypothesis is that it's the young, an age group between 19 to 24 are currently being infected, and we're then going to see a subsequent wave in the older age group, and we're familiar with this data in the media. But ultimately, we need to see what happens, but we do need to be prepared. As I say, the northwest of England is already seeing this increased occupancy in intensive care. Going throughout the globe, there is wide variation in the pattern of the incidence and prevalence and deaths. And worryingly, Southeast Asia is seeing a very sort of parallel, mirrored rise in deaths along with cases. And whilst everyone was worried about what would happen in Africa with the sort of the low availability and limited availability of intensive care beds, the deaths are also falling in Africa. So this remains, many aspects of this disease remain a mystery. I'm going to skip this slide. What is interesting is that the 5-year average death rate on a week-by-week basis in England is falling. And right now in London, it is 16% below the preceding 5-year average for the weekly deaths. So the question is all of the shielding and all of the mask wearing and distancing and hand washing actually protecting other people from other infectious diseases? Who knows? It is very difficult. The location of the deaths, this slide is from the Office for National Statistics, and the weekly death rate, clearly there is a significant increase in number of death rates in care homes around April and May, but there is an increase throughout the whole year in deaths at home. And this is clearly a worry with a reduction in deaths in hospitals. And the daily death rate on the left-hand slide, the side of the slide, we have data of the daily incidence of positive cases only a few days ago, and then on the right-hand side, yesterday and the day before, we were up to 6,800 cases, which is the highest daily rate of positive tests in the United Kingdom throughout this year so far. So things are really hotting up. There is definitely a lag between the UK and the rest of Europe, but we do appear to be following the same curve as Spain and France, and we're between 2 to 4 weeks behind, and this is a worry. Interestingly, this slide shows the very low death rate in Sweden. The ongoing trials are REMAP, CAP, Genomic, ISRIC, as well as the recovery trial, and to summarize, this has been an awful pandemic. We're still in the early phases. Public health measures are key, the vaccine is awaited, and there are over 140 different candidate vaccines in production right now. Antivirals and dexamethasone certainly have a role, and anecdotally, we certainly at the Royal Free have used monoclonal antibodies against the spike protein very effectively to clear the virus in patients who are unable to clear the virus with appropriate clinical resolution. Anticoagulation is key, the appropriate ventilatory support, and really lower down is limiting the cytokine storm. And I think that the population where the cytokine storm is relevant really is much smaller than we previously worried. Any questions?
Great, thank you very much, Jim. That was very interesting, and especially to hear it from the epidemiological and virological perspective. We do have some questions. Sam, would you like to post them?
Sure. So there's a question that's come in that says, could you just go a little bit more into the protocol for TEG-based VTE management?
So Jaya, I'm currently not seeing the question, so any assistance in reading those out would be helpful. Sorry.
So the question was, could you share your protocol for TEG-based VTE management?
That's a very good question, and that's part of a research trial and study by one of my colleagues. And if I get permission from Dr. Mike Spiro, I'm very happy to do so, absolutely.
And so my question was, Jim, that the new sort of weapons in the armory that we have against the second wave seem to be remdesivir and dexamethasone. Is there anything else potentially on the horizon that that may get used during this round of outbreak?
Well, I think we're also involved in the PACA trial, which utilizes nebulized TPA. So it's not just to break down any thrombi within the pulmonary vasculature, but actually much of the pathophysiology of ARDS in the alveoli is fibrin dependent, and inhaled TPA has a dramatic response in a gas exchange. So there are ongoing studies with that. Clearly, inhaled prostacyclin, an old friend from the early days of ARDS, may well play a role. And clearly convalescent plasma is out there, but of course that's a blood product. It's about the availability and utilization of it. Is it going to be pro-inflammatory? It's very, very difficult. Anecdotally, we've only used it in 2 cases, but monoclonal antibodies against the spike protein have had a phenomenal response and cleared the virus very rapidly. And one patient had a measurable PCR positivity in her blood for 70 days post-COVID. And as soon as we gave the monoclonal antibody, the PCR was negative, the virus disappeared, and we had clinical resolution of a disease that persisted for 70 days. That may well be because it's clearing antigen rather than live virus, but anecdotally it certainly had a dramatic effect. I know that the next speaker will be very sort of keen on evidence-based medicine, and I would sort of reiterate that it is very important that we engage all of these therapies in trials, because otherwise we will never have the answer to this question. And so at the peak of the pandemic, 100% of all of our patients at the Royal Free were enrolled in trials, and therefore some of them will have been in the placebo group, and we need to see in due course what the trials show really.
Right, lovely, great. Thank you very much, Jim. That was truly interesting. We're going to have to move on, but thank you very much for sharing. Thank you. So, right, so and now with great pleasure we move on to our next speaker, Professor Rupert Pearse. He is a National Institute for Health Research Professor in Intensive Care, and he leads the Critical Care and Perioperative Medicine Research Group at Queen Mary's University in London. His main research interest is in improving patient outcomes following major surgery, and he has led numerous large multi-center randomized trials, epidemiological studies, and mixed methods research projects. He is also a practicing clinician at the Royal London Hospital, working as an intensive care consultant. So with great pleasure, I hand over the stage to Rupert.
Thanks very much. Yeah, and just to pull up from Jim's point, I think that there can be a lot of confusion sometimes around research and how we use it to improve patient care. I'm an applied researcher, so I spend a lot of my time on the question, does it work? And that means, does it work in the real world? Does it work with all the warts and irritations that happen in day-to-day clinical practice that get in the way of things being effective? Jim's talking a lot about, can it work? That's more efficacy studies, where they're looking at translational research and novel new ideas that have validated biological mechanisms. And the point Jim makes, which I completely agree with, is that we have to look at these things in the context of clinical trials. If you do that, you're always going to be safe, because you're fine to take an anecdote or a promising case series and move that into the next stage of a trial. What you're not okay to do is immediately implement that into patient care, because it will probably result in excess mortality, often because you're giving the drugs to the wrong patients, the ones who won't benefit, and they just get side effects. So I think Jim and I probably, if we sat over a pint, would very quickly agree on what we know works, what we hope would work, and what we think we should do about that. So I think it's a common belief that those who spend a lot of time doing applied research and talking about that, and those who do translational research and spend a lot of time talking about that, don't actually agree, because they usually do, in my experience. Anyway, on to the talk. I'm going to start my slides. Can you all see that? Yeah, is that okay?
Yes, thank you.
Cool. So I've been asked to talk about COVID care pathways, which I don't know a massive amount about. There are lots and lots and lots of publications on this, as there are with pretty much everything COVID at the moment. And a lot of the evidence base out there is very, very low quality. So it's hard to make sense of it. So I'm going to talk a little bit about what we do know about COVID in the perioperative period, what we do know about perioperative care pathways, and how we can sort of integrate that learning. I do have some conflicts of interest, which I've listed here. For those of you who know me, I work at the London Hospital, which is in East London. We were certainly at the forefront of the first wave, as I think Jim was too, and it looks like we're going to be very much at the forefront of the second wave, where I'm due in on clinical on Monday morning, and we'll be opening a whole new COVID ward for ventilated ICU patients, which will probably serve a big chunk of East London. So COVID is here, it's real. We need to politely call out those who pretend that hospitals are empty and continue to challenge those, because if we stay silent, then there are some that will simply believe that that's true when it isn't. Surgery in peacetime is a vast industry worldwide. Estimates vary, and it depends a lot on how you define surgery, but more than 300 million surgical procedures performed worldwide each year. We don't know what the actual mortality rate is, but if we assume a 1% mortality rate, which is not unreasonable, then we're talking about 3 million patients die each year within 30 days of surgery. Now, some of those are dying from the surgical disease, not from the quality of care that they might have received. But I don't think it matters. What matters is that surgery is an opportunity to improve people's long-term quality and quantity of life, whether that's by being better at delivering perioperative care, doing better surgery, or treating the index disease more effectively. I don't think it really matters. And this occasional battle we perceive between sort of who's responsible for those outcomes, I don't think that's important. I think what's important is we see it as an opportunity to improve patient care. And that really underpins a lot of my work in my career. When I started out sort of 15, 20 years ago, a lot of people would say, well, quality of care's fine, you know, surgery is safe, we don't need to do anything to improve it. Now, in the last, certainly in the 15 years, perioperative care has improved dramatically, and outcomes have improved as a consequence. And you don't hear anybody saying that we don't need to try and improve perioperative care anymore. And I sort of reflect on that change in attitude There's a lot of it is driven by people like the members of TRIPOM. We just go, well, that's not the point. The point is there's an opportunity to do something better, and that's an opportunity we should take. And I strongly support that attitude and culture throughout medicine, but especially in perioperative care, because the sheer vast number of patients give us a huge number of opportunities. They also present some of the challenges. And just to put that into context, we used to all the time, but less so now, talk about 30-day survival after surgery, as if once the patient got to 30 days, it was a result, they'd survived and we didn't need to worry about anything. And my point is that very few patients have surgery with the main success of being alive 30 days later. Most people have surgery because they want to live a lot longer than 4 weeks. Most of them want to live quite a few years, but they're also hoping for a good quality of life as well as the quantity of life. And so we need to see surgery not as an acute intervention, but as part of a patient's lifelong health journey, something that improves either quality of life, quantity of life, or both of those things. And we need to understand that when the patient has a complication after surgery, it impacts on the success of surgery, as well as adding a new bad thing into that patient's life. So we need to see this acute event, in this case surgery, but whether it's critical care, surgery, admission to the emergency department, it's an acute event that offers an opportunity to modify that patient's long-term life health journey. And that's how I would see surgery, and that's why I think it's so important. And the real index patient is what we have called, and perhaps less so nowadays, but the high-risk surgical patient who usually undergoes major surgery. They're usually elderly, or at least over 60 years of age. They pretty much always have some form of comorbid disease, and a lot of them undergo surgery in a non-elective environment when there's less opportunity to plan. And so a lot of the focus in my career has been on the high-risk surgical patient. But increasingly, as we grind down the problem and we get better at that particular niche aspect, I think that our focus is shifting to the entire pathway for all patients and how we can ensure all patients have a good outcome, or that we take every opportunity to improve people's outcomes still further. So whilst a lot of it is about this patient group, I think increasingly not all of it is about that group. We need to remember that this is an effectiveness debate. So rather like the comparison with my views on interventions for COVID, we can get very confused about whether something works or does not work. Perioperative care is mainly focused on quality. It's mainly focused on how we can be better more of the time. And the way I describe quality to people, it's about being more of the best of yourself. So it's not saying that we're bad, that we aren't any good, that we do bad stuff and we have bad outcomes. It's about comparing that best day at work that we had, where everything went really smoothly, where the patient didn't have minor complications of nausea and vomiting after surgery, or didn't have poor pain control, they didn't get pneumonia, they didn't have bad outcomes, or they didn't die, versus the worst days we have where nothing seems to go right and it's very difficult to get that really high quality patient care through. And we're just trying to have more of our good days. And a lot of that revolves around perioperative care pathways, and a lot of it can be measured with tools like this funnel plot here that show that there are some hospitals that have quite low risk adjusted outcomes in terms of mortality, and others that have quite high risk adjusted outcomes. There are very few extreme outliers, but what these graphs tell us is not that you're bad and I'm good or the other way around. What it tells us is that maybe there's something you're doing today in perioperative care that we need to listen to, that we could learn from, because your outcomes seem to be better than ours. Maybe there's something that we're doing that you could learn from. And it encourages that idea of quality. It encourages that idea of being at the top of our game more often. And this is very much an applied research angle to things. We're not doing anything exciting. Jim's talked about some really fascinating translational research. Applied research I like to think of as being very, very boring, very, very dull, and very, very geeky. But my argument and justification for that is that no patient wants to be exciting. No patient wants to be interesting to doctors. And certainly when when our loved ones go into hospital, we don't want anything exciting to happen to them at all. Thank you very much. We want them to have a very, very boring stay in hospital with no interesting events whatsoever, and to come home and get on with their lives. Now, moving on to COVID just briefly, a lot of the really high quality research has come from this, the COVID Surge Collaborative, which is really led by the Global Surge Group that's based at Birmingham University, Anil Bangu, James Glavey, amongst others, who've really done some lovely global health research on COVID. And in this study that was published in The Lancet, they showed that patients who had major surgery and developed COVID afterwards had a very high mortality rate of over 20%. And so it became very obvious that those patients, the interaction of COVID-19 and surgery was a very, very bad thing for patients. But I suppose we have to remember, first of all, that this patient group were probably having surgery because they absolutely desperately needed it. And so they're a high mortality group. And that the focus of global surgery in general has been on general surgery, GI surgery. And it may possibly have missed some of the more day case style work and focused on the big high risk patients. And that may explain that mortality rate. So that's not to say that it doesn't matter, but it is to say that there may be other surgical patient groups that weren't quite as high risk in terms of having surgery during the pandemic. So the question is, how can we manage that? Now, the other thing that we have to remember is that surgery is getting cancelled in vast amounts. And again, this is a COVID surge global estimate of 28 million procedures globally cancelled in the 3 months during the peak of the pandemic. And two colleagues of mine, Tom Abbott and Alex Fowler, who are anaesthetic trainees, who do a lot of epidemiological research of really high quality. They've got this paper, it's not formally published yet, but the pre-pub's available on Medrex. And I think it'll be published quite soon now. It's just coming to the end of its peer review. But they estimated, it's a few weeks ago now, but their estimate was of a deficit in the NHS of 20 million patients by next March. Now, I think now looking at the progress in surgery that estimate's possibly a little bit on the optimistic side. So we're seeing a vast number of surgical patients have their procedures delayed or cancelled. Some of those may be procedures we can wait for. They may be day case procedures. They may be symptom controlled procedures such as joint replacements, but some of them are for cancer. Some of them will be life-saving. And in the wrap-up of COVID-19, which won't happen this year, I think one of the big harms we will see is untreated cancer, untreated heart disease, and other major problems like that the NHS has not been able to focus on. So we know that COVID is having a big impact on the patients who develop the disease, but we also know it's having a big impact on everybody who would normally be having our care as part of the NHS. And I think we're seeing this frustration boil over in society amongst people who maybe have cancer and are having their treatments delayed, but also amongst our colleagues, some of whom are desperate to get back into the operating theatre and start treating their patients because they see them in clinic or they see them in e-clinic, and they know that they're suffering and they know that their outcomes are going to be worse as a result of all of this. So I don't have the answer on how we reconcile those competing priorities, apart from, I think, our approach should be one of benevolence and understanding rather than one of rules and judgment. I think we're slipping into a very judgmental, rule-based approach to pandemic management at the moment, which I think is going to make a lot of people very, very stressed. We aren't going to make every decision right ever. We're going to make a lot of poor decisions, and we're not going to know that until months and months from now. So I think we need to do our honest best, still like we did in the first wave. A lot of you will be familiar with the enhanced recovery after surgery pathways, and this is what you think of as a pathway. This is what we hear about for many years in lectures at conferences. But I don't really see IRAS as a pathway at all. I see it as a collection of interventions. And that's not a criticism of it. It's just the word pathway is perhaps incorrect, and maybe the word standard would be a better word. Now, there's a lot of debate about whether we have robust evidence that IRAS improves outcome. I think a lot of the interventions are common sense. Some of the interventions are a reasonable bet. Some of the interventions do need to be studied in randomized trials and are being studied in randomized trials so that the IRAS can be improved as a package. But what it isn't is a pathway. And right now, in the midst of this pandemic, we need pathways that work. We need ways for patients to safely flow into hospital, have their surgery, and flow out of the hospital with the minimum of fuss, certainly without catching SARS-CoV-2, and we really, really hope without developing the disease COVID-19. Now, if we do look at some pathways, I'll show you a few that I've been involved with studying. They are a lot more complicated than a collection of interventions. And this is the evidence-based care pathway for emergency laparotomy that we drew out in EPOC, which was a cluster trial of care for emergency laparotomy patients. And I usually have to start by comparing this to the London Underground map and saying that the London Underground map is very complicated, but we straight away zoom in on the line or the lines that we're interested in and which stations we're trying to get to, and we can ignore the complexity of the wider pathway, because otherwise people can't come to terms with it. But perioperative care pathways are this complicated, and worse still, your pathway in your hospital differs to my pathway in my hospital, often quite a lot, and sometimes pathways differ quite a lot between specialties or even within specialties. So this complexity that you see is not only is there the complexity exists, but it's highly variable between different patients in different hospitals with different diseases. So having hardwired pathways is probably not a good idea. Just to reiterate that point, this is a shared decision-making pathway for major joint surgery in one hospital. And this isn't even the surgery itself and the post-op care. This is how you get to the point of making a decision to have surgery. And we've been studying this in a program called ASARUS, where we're looking at shared decision-making ahead of surgery and hoping to find ways to improve the information that we give to doctors and patients so that they can make better informed decisions, and hopefully decisions that they regret less. Because we all know that sometimes our patients go into surgery really, really wanting surgery, and afterwards really, really regret that decision, and that can result in criticism of doctors, surgeons, anaesthetists, and others in the perioperative period. So pathways are really, really complicated, and they vary very widely. And just to really ram it home, this is the global health context pathway. This is emergency abdominal surgery in Sri Lanka, and some collaborators of ours with NIHR funded program of global health research. And you can see again, even in the global health context, where there are fewer interventions and there are fewer moving parts in the healthcare system, perioperative care is very, very complicated, and the pathways are very, very complicated. So giving you a simple lecture on how a pathway works for a brand new disease that we're still coming to terms with, to solve the problems that we've really only just started to solve in terms of perioperative care. I'm not sure I'm really going to be able to do that very well, but what I can do is highlight the principles of great perioperative care. And I think you can do no worse than look at the resources on the Royal College of Anaesthetists website on perioperative medicine, and the Centre for Perioperative Care, cpop.org resources, which are also very valuable and very interesting. This character, as some of you who watch the video will know, is Doug, and we followed Doug in an animated story through his preoperative preparation before surgery, looking at things such as, but not confined to, preoperative risk assessment in various different ways. We looked at his care during surgery and the various different interventions that you can use in that context. Examples being how we set up our ventilator for perioperative care, something we do for every single patient, and evidence that we can do that slightly differently in certain circumstances and influence our patient's outcome as a result in terms of pulmonary complications, saving no time, so wasting no time in doing that and costing them money in doing that. So simple things in applied contexts that can improve patient care. Also that there are very important things that happen early after surgery. And for me, a lot of that revolves around how we take critical care technologies of various types and scale them up so they're less resource expensive. They can be used in a more patient-centered way wherever the patient is, rather than in a room that has the label intensive care. And we really, really need to learn how to take critical care technologies of various different types, a lot of them very, very simple, and deliver them at scale to improve patient outcomes. And just to be really clear, the most important critical care technology is the ICU nurse. Trained ICU nurses who are empowered to deliver interventions immediately to the patient that they're caring for, who deliver them with extremely high quality, with very, very high rates of acuity and compliance. They have immediate access to doctors who understand what they're trying to achieve and facilitate and support them in what they're trying to achieve. And they work within a multi-professional team of doctors, nurses, physiotherapists, dietitians, cleaners, porters, ward clerks, and so on. And it's that culture of multi-professional teams that's worked so brilliantly in COVID, which is why critical care has played a lead role, and why the relationship between intensive care medicine as a specialty and anaesthesia as a specialty has immediately been a huge strength and an asset for us, as we, lend ourselves to dealing with a disease that we've never seen before. And we can do that again in perioperative care pathways, but we really, really need to understand and need to be adaptable and versatile, rather than creating hardwired pathways that we empower each individual person at the bedside to use their sense about what's needed, but being aware that we have to have certain rules. And of course, the biggest and most overwhelming rules in COVID are the infection control rules. And we're already seeing a very different attitude. In my hospital in the first wave, we kind of accepted that we couldn't properly socially distance. We kind of accepted that that put us more at risk as healthcare practitioners. And whilst we rigidly applied PPE guidance in the clinical areas, in the doctors' offices and in the canteens and in the restrooms and so on, we perhaps weren't as strict as that. This time around, it's incredibly strict, and rather in the same way as on public transport, we're being called out if we don't wear masks and if we don't distance. My worry is that although I think that's the right thing to do, what we're asked to do, rather than questioning the rationale, I think that it risks making us all very, very stressed continually on the way to work, during work, on the way home from work, and that there's no escape for us from the stress of what the pandemic is doing. And I think kindness is the solution to that. Some of you may chuckle, I'm one of the grumpiest people I know, and I'm sometimes accused of not being as kind as I ought to be. But it's clear and simple to me that the words of kindness to each other as we make these pathways work is going to be the glue that sticks everything together. So moving on to later after surgery, remembering that surgery itself has long-term implications for patients' health. And we know that COVID, this concept of long COVID, which I think is a really nice turn of phrase, that basically tells people what we've always known about serious acute illness for patients who have comorbidities or advanced age, is that the impact of acute illness is lasting. It lasts for months, it lasts for years, it impacts on patients' quality of life and their quantity of life. And also remembering that surgery in itself is a sentinel event where we often have the opportunity to look at patients' other medical problems and their wider health. There are opportunities for secondary disease prevention, improving the care of comorbid disease, and taking that holistic approach to patient care, rather than delivering a great anaesthetic or delivering great perioperative care, we see it as an opportunity to improve that patient's quantity and quality in life in every way that we can. And so rather than having rigid pathways, we need to create those opportunities to be versatile and flexibly respond to what the patient needs. A little word of warning, I am a big fan of perioperative medicine and the opportunities it creates to improve patient care, and I'm a big fan of the Centre for Perioperative Care. But we need to be a little bit cautious about making bold claims, and this statement about perioperative care pathways reducing complication rates may be true, but really you can't wheel out applied evidence that proves this statement, because the pathways are all different and it's impossible to do randomized trials of pathways. What we can draw attention to is that patient care is getting better and pathways are becoming more embedded, and common sense tells us that the pathways are a big part of that improved patient outcome. But if we make very rigid statements, and if we make perioperative care pathways more of a religion rather than a culture, we start to say that we can't change the pathway because we know it works. And when you find problems with the pathway, you can't adapt it and improve it because, hey, we already know it works and we already know it's perfect. And we've got many opportunities still to improve patient care, and we need to take those opportunities wherever they are. So rather than saying we know pathways work, perhaps we should be saying we know pathways are a good thing and we know we need to keep working to improve them at any opportunity. And that's not to say that we are all moving in the same direction trying to do the same thing. It's just a little bit about the way we encourage those around us to adopt improvements in patient care. And in some ways, it's like the sepsis 6 and all of these things. There's a sort of approach that some have described as evangelism, which can work, it can help, it can do a lot of good, but then you reach a point where it becomes so rigid and like a religion with very strict rules that you can't adapt for your own context, your own hospital, for your own patient in your own particular situation. And we do need to be a little bit careful about that, or we will reach a glass ceiling where we can't improve patient care anymore until it's shown to be failing. And that will hold us back. And you'll have a situation like I worked in 15 to 20 years ago, where everybody passionately believed that we were brilliant and we couldn't improve. And the work that you guys have done over the last few years have shown that's not to be true. So I think that's probably me time up. I'll stop there, but I'm very happy to take any questions. Thank you.
Great, thank you very much, Rupert, for the very thorough and thought-provoking talk. I had a particular question. You mentioned that all pathways really need to be tailored to the department in which we worked in. For example, if you worked in a small hospital and you were trying to develop a pathway to improve patient care in this difficult time, where would be a good place to start?
It's a million-dollar question. I mean, I think anywhere that you can start making progress is important. In quality improvement, there's a lot to be said for easy wins, developing, making early successes, and any success begets more success. So once people around you see that things are getting better, they'll start to believe in what you're trying to do, and they'll support what you're trying to do, and you'll find that resources come your way so that you can start to improve things. So I think the first thing is to just think about, well, any opportunity to improve things is a good opportunity. Start with the easy wins and take it from there. In a philosophical sense, I think we need to remember that surgical care pathways start with the moment that the GP picks up the phone or sends that email to the hospital to ask a surgeon to consider a patient, because that usually triggers the surgical care pathway. And we have to remember that the care pathway starts long before that hardwired decision to do a surgical procedure happens. And often the patient doesn't get that actual green light to go, no, it's definitely surgery, until a few hours or a day or two before surgery, even though they've been worked up for surgery for some weeks or months. And that failure to recognize that a workup for a disease is our opportunity as perioperative medicine, perioperative physicians, to get in there and improve patient outcomes is quite important. So I would say as early as possible, but I wouldn't let as early as possible get in the way of you doing the easy thing in front of you, wherever in the pathway that is.
Yes, okay, great, thank you. Another slightly, sorry, a bit of echo, controversial question is that you mentioned there may be a 20 million backlog of patients requiring surgery. Do you think there will be a push towards rationalization and perhaps use of risk stratification to rationalize these patients in the future?
So I mean, the first thing to do is that I'm not a believer in crystal balls. I don't know what today's lottery numbers are. I don't know what the future holds, and I can't tell you what's going to happen to your patient. So prediction, which we're obsessed with, absolutely obsessed with prediction. We do all these risk scores, most of which are fundamentally flawed, give us very misleading information. And fortunately, we don't act on the misleading information. So why we obsess over risk prediction, I don't know. We need to be really, really careful about predicting what will happen to our patient. What we should be doing is the best for the patient in front of us that we can, and as we are doing, working to improve that care, not just for that best patient care, but for all patients. So that's the philosophy we need to have. If we're talking about rationing and triage, that's something that society needs to lead, not us. We didn't make the pandemic. It's not our fault that this has happened. We're trying to be part of the solution, and society needs to decide, if we can't do 20 million procedures next March, then which ones do we want to do? Shall we focus on cancer? Shall we focus on heart disease? Shall we let orthopedics go to one side? That might seem logical if you're an anaesthetist or whatever it might be, but actually what we'll find is that we leave vast sections of our health system dormant and not doing anything, and actually we probably can offer some of the most urgent cases who need joint replacements, because that capacity is sitting there at the moment doing nothing. So it needs a really sophisticated interpretation. It needs to be regional. We know that COVID is a regional disease, and I think it's very frustrating when we see a national approach to something that's subnational, local, and regional usually. I think that's changing now, which is good. And it's obvious to me that people get very frustrated if they say, for example, live in Manchester, and they feel that the local guidance and procedures are based on what might be happening in London. And that's not sensible. So we need to be prepared to make our responses local or regional in terms of pathways as well, and be adaptable in that. But most of all, we need to be having a conversation with society about what we can achieve. We shouldn't own, as doctors, that 20 million backlog and say it's our fault. Instead, we should say, look, we've got a problem. We need to solve the problem. Here's what we can do. Here's our suggestion. What do you think? And I think as a society, we need to accept that we're going to do the best we can do, that we can't get everything right here. We can't get all the cancer care perfect and cure every patient with COVID, and, you know, avoid all the health inequalities that we know are happening right now. We can do our best, but we can't prevent every bad thing.
Sure, lovely. No, it does end up, it could potentially be very political. Great, lovely. Thank you very much for a lovely talk and giving up your Saturday morning. And I think that's us wrapped up. So I'm going to just switch over to the organizer. Thank you much, Rupert.
Pleasure.
And what a great way to bring our breakfast series to a close. Our webinar series are all recorded, and we'll be posting these on our TRIPOM website. So I just wanted to say a huge thank you to all our speakers today for giving up their Saturday morning to educate us on these immensely relevant and topical subjects. And thank you to our attendees for joining us. Please fill in the feedback at the end so we're able to improve our future sessions. And finally, I just want to say a big thank you to the TRIPOM team and our sponsors, Edward Life Sciences. Without our hard work and their generosity, all of this would not have been possible. So thank you all for dialing in and have a lovely weekend. Bye now.